Today, Matthew, I'm going to be Mr. Cameron Lindsay because this is his study that a lot of people did contribute to. So the early use of botulinum toxin post-stroke spasticity. Well, we know what stroke is. So what is botulinum toxin? Well, it's a neurotoxic protein produced by bacterium Clostridium botulinum. We inject it into a muscle and it sticks and it's really safe. It's a chemical deinnervator, so it stops a chemical called acetylcholine being released from muscles, and you need acetylcholine to get a contraction of your muscle, and if you can't contract the muscle, you can't stand, you can't move, you can't really do anything. So it kind of paralyses a muscle. There are 3 products. This particular trial was sponsored by Allergan, that produces botulinum toxin. For equal reasons, and for ABPI, there are also Ipsen produced Dysport and Merck's produced Siemens, so we're all fair across the patch there. Okay. So the objectives of the UBOS trial, it was funded because whether using botulinum toxin early can prevent the loss of movement and stiffness and ultimately improve function. If you're stiff and you can't move, you can't really function. So the science of it, what is spasticity? So you have a stroke, which we know, as Bruno said, is an acquired brain injury. So the spinal cord is very, very excitable, sends off lots and lots of signals, and it's normally kept under control on an equilibrium by the brain. But unfortunately, when you have a stroke, if it's in a particular area of the brain, you lose that seesaw yo-yo. So all this hyperexcitability, everything working really, really fast, and there's nothing that goes, whoa, calm down. So we lose that, and as a result, muscles get really confused as to whether they should work really, really hard, and then when they should really relax. And once you enter the cycle, it's very difficult, as some of our patients here can tell you, difficult to get out of. So we lose the ability to control the spinal cord, and as a result we get abnormal muscle activity, and we call it spasticity. The actual physiology behind it, there's lots of scientists out there, it is still pretty unknown, so there we go. So, but that's what we understand at the moment it to be. Can you all hear me, by the way? Mm-hmm. I'm a little loud enough. Okay, so normal practice, people begin therapy. As a therapist, we try and control the muscles through handling various other adjuncts as well. We try and control that abnormal muscle activity. And then people, the first line, were given antispasmodics, so oral drugs. But unfortunately, they have a systemic reaction. And when you're trying to recover from a brain injury, you need everything in your camp. And unfortunately, antispasmodics, so they try and dampen everything down, can impair your thought processes, your cognitive ability that we've all been discussing today. So, you can't really ever say you can reach your optimal level of recovery post-stroke. But then we discovered botulinum toxin. By the time we give it to the muscle, often we're trying to chase the tail. Traditionally, spasticity has been managed sort of 3 months post-stroke. This is very innovative because we can see it coming through more and more, and that's because we're better at managing stroke. We're logistically all put in one place, we're reconfigured. So now we're starting to look at it days within having a stroke. So we thought that's normal practice, but if we combine 1 and 3, so begin your early therapy, we know what you have to do and it's right, so we should be done, but combine it with botulinum toxin before we get in this ever decreasing cycle of stiffness, loss of movement, contracture, and then into abnormal postures, which then go on to affect everything else to do with movement and then ultimately to do with function. So the results, we recruited 120 people from SWBH with severe stroke, and that meant that they couldn't use their arm at all. 116 of these were seen to go on to develop spasticity. 16 recovered function, so they were not injected because this stuff, as I said, paralyses part of the muscle, so if they're not trying to move your arm and I come along and paralyse it, you're not going to be very impressed. And 7 of the remaining 100 became unwell or decided not to have injections, so it left a cohort of 93. It was a double-blind trial, so you have either toxin, true toxin, or you have what we call a placebo, which is, in this case, was salt water. The pharmacy department were absolutely phenomenal on this trial. Sue, you were part of it. It was literally a case of, I've recruited and Sue had to drop everything. Placebo, where we are in the trial, they'd come up, we'd get somebody on the ward to reconstitute it. I would be blind, I wouldn't see any of it. They'd go into a little treatment room. They even had to drop the vial in to get rid of, so I couldn't see if it was placebo or whether it was the actual toxin. Even special little disposable where we put the sharps boxes, so Sue could scurry it off so I could then come along and go, what was used? So it was truly blinded, which is phenomenal, and it puts a huge amount of effort in. The botulinum toxin group, and the control group were 48 to 45, so male to female, and their NIHSS scores. So with stroke, as we know, it's very bespoke and individual. This part of the trial was trying to get very similar groups, so we're trying to limit the variations that we had. One group, as we said, received botulinum toxin injections into 6 muscles of the arm, and the other group received injections of water into the same 6 muscles. Everyone was followed up at 2, 4, 6 and 12 weeks after the injections, and then 6 months after the stroke. And I have to tell you, Cameron was religious about it, with his little table that he had to go and measure people with his little measuring of surface markers. He was here, there and everywhere. He went everywhere to follow up his patients. He was very good. And what did we find? Well, Cameron found, people who received the placebo were 8 times, so they didn't receive toxin really early post-stroke, they were 8 times more likely to require injections of botulinum toxin in the next 6 months. So, and probably, what we could probably tell you now is by the time they needed that toxin, they probably needed an awful lot of toxin. So, from the NHS point of view, it costs a lot of money. You're 4 times more likely to require a splint. What we mean by a splint is something that's made of a hard material. It's passive. It does not look pretty. It's bulky, so it's difficult to put your arms through your coat and your sleeve. So they're not nice. You're 2.5 times more likely to be taking at least 1 painkiller. Spasticity is a big driver of pain. If you imagine all your muscles bunched together, abnormal positions, it drives pain. And again, having another drug on top of what you're already taking is not good for the rest of your health. And they're also 1.8 times more likely to have recovered some function. Though this may have been chance, we do know there's spontaneous recovery post-stroke. So conclusions, told you I'll get there by 4. We can safely use botulinum toxin. We get it into you using your ultrasounds, which means we can see the target tissue. We are fundraising for an ultrasound machine, we'll donate as well. Botulinum toxin does reduce spasticity. Elbow and wrist contractures, so contractures are when your muscles become so short, they lose that elasticity and then they're stuck, and then the joints often become rigid. It was significantly slowed using botulinum toxin, and there's some evidence that more people in the Botox group recovered some more function because we allow sustain the muscles to be elastic to get over the stroke to then get onto more function. Cameron would like to thank everybody in SWBH NHS Trust, so Sissy, Sue, moi, and all the patients, of course, that agreed to participate in the trial, and 120 people who had survived a life-changing event and their families. Each of you showed miraculous altruism, and you are a credit to humanity. Without you being signed up and participating in trials, we cannot progress the world of stroke and recovery any further. And currently, Sissy's won the Best Newcomer 2014 to the West Midlands Stroke Research. And Cameron has won the Robert Williams International Award of 2015 for the Chartered Society of Physiotherapy, and also the Werner Wright Prize in 2015, the Society of Research and Rehabilitation. So, and I think he will, once his results are officially published, I think more and more awards will come his way, and I'll be on the back of that one, I can tell you now.